Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.
You're listening to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. With us is Dr. Robert Popovian in Washington, D.C. He's a pharmacist, an economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation.
And joining me, as always, is my good friend, Ben Blanc, dialing in from the Jewel of the Midwest, Indianapolis, Indiana, and our Associate Director of Digital Production and Engagement. Looks like the Midwest is going to have another cold wave coming, Ben. What's going on?
I know, and we've got another never-ending winter this season, and that's why I'm actually traveling to Washington, D.C. this week.
Is this to get away from the winter, or what is going on in D.C.?
Yeah, well, that, and to attend the World Vaccine Congress with you, of course.
That's right. We are all looking forward to that and those important gatherings where science, government, most organizations get together and share the progress and research on topics related to vaccines. So really looking forward to this.
And we'll actually be talking about vaccines with not one, but two guests.
That's right. We've got my good friend, Dr. Wayne Winegarden, who is the Senior Fellow in Business and Economics at the Pacific Research Institute and the Director of PRI, Center for Medical Economics and Innovation.
And we also have Esteban Rivera, Associate Director of Data Science and Economics at GHLF. So let's get to it. Well, thanks for joining us, Wayne and Esteban.
Thanks so much for having us. Great to be here.
Thank you to both of you. I'm very excited for the conversation.
All right, and before we start our conversation, Wayne, Esteban, do you mind introducing yourselves to our listeners?
Of course. I'm Wayne Winegarden, as Robert said, Senior Fellow at the Pacific Research Institute. We're a free market think tank located in California, where we work on a wide variety of pressing public policy issues, both for California as well as for the nation overall. I'm the Senior Fellow in Business and Economics, so I cover a wide range of areas that include healthcare and particularly drugs, vaccines, all sorts of kind of the how do we make these essential tools affordable and innovative.
Yeah, and as Ben said, I'm the Associate Director of Data Science and Economics at Global Healthy Living Foundation. In simple terms, I'm the math and data nerd here, so I work across all of our teams, sometimes on the clinical side, here in this case the economic side, and on the market research side as well, to conduct robust analyses to make sure the work that we're pushing forward is done in a rigorous way.
Well, thank you both. Welcome aboard. So, Robert, you know how it goes. We always start the episode with a number, and today that number is 59.7%. So really about 60%. Can you tell us what this number means?
Well, what this means is that according to the Center for Disease Control, in the latest flu season, nearly 60% of all flu vaccines were administered in pharmacies, which is a clear indication of pivotal role pharmacies can play in our fight against preventable diseases. That's why today's episode, we're going to really discuss the positive impact of removing regulatory legislative barriers to allow pharmacists and pharmacy technicians to vaccinate.
So, Robert, we're going to stay with you for my first question. And I think that before we get into the weeds of this new report that GHLF just released, it's important for our listeners to hear the reasons behind the study. So, Robert, could you share what motivated you, Wayne, and Esteban to undertake this particular study on pharmacy-administered vaccinations?
So, Ben, this was a journey that started about 3 years ago in the first paper that Wayne, Esteban, and I collaborated on. In that paper, we investigated what is the access to pharmacies in low-income communities versus physician offices who also immunize. And we found that clearly there's better access in low-income communities, which are overrepresented by minorities. These are both racial and ethnic minorities. And that prompted us, GHLF and myself, to look at the second study that we did. And in the second study, we collaborated with IQVIA, and what we found is that pharmacists by far are the healthcare professionals that patients or adult patients want to go get their vaccines in. In fact, post-pandemic, almost 90% of all vaccines for adults have been administered in a pharmacy. And most recently, we have data with newer vaccines that is the case as well. So that's the second reason. And then the third reason, frankly, is because over time, I've been working on this issue of immunization and access to immunization, especially for underserved communities. I've realized that we create so many regulatory and legislative barriers in the states, and these barriers are not going away. And nobody has ever stepped back and thought about, we've created this convoluted Byzantine model. What is the cost to the system? But not only the direct costs regarding, removing these barriers or getting around the barriers or having to manage the barriers, but also the human costs because of the patients not having access to vaccines at the pharmacy, similar to their physician peers, which are allowed to immunize patients as soon as a vaccine is FDA approved or is recommended by Center for Disease Control. So those are the three reasons why we were motivated to do this study, and Wayne and Esteban will get into the nuts and bolts of what we try to accomplish.
Well, I'm stuck on the 90% number. That's definitely an eye-opening perspective. And I think it really sets the stage for understanding the importance of this report. So, Wayne, moving on to the core of the study, what would you say is the most groundbreaking finding from your research, and how could this change the way we look at vaccinations?
Well, I think, and Robert was just alluding to this, one of the most important things I think this study does just at the outset, it actually gets our arms around the trunk of the tree of this Byzantine system, I like that phrase, that we have in terms of the states imposing regulations. Remember, these are FDA-approved vaccines. So these are vaccines that have already gone through the entire approval process or demonstrated their safety and their efficacy towards whatever disease we're talking about. So now we just have unnecessary burdens. And it's a very complex kind of structure. And so we actually kind of mapped out so you can actually see, one, just how ridiculous some of these state regulations are, how burdensome they are, but also the variation across the states. And that becomes a problem because, again, if we're trying to get these vaccines out to as large of a population as possible with as fewest costs as possible, that variation of regulations, that also has an impact because that requires resources and time to figure out and manage all of these different systems. So I think one of the important, just from the very outset, is the idea that here's the actual pathways that you have to go through and just documenting that. Once we documented that, we thought it was very important to talk about what's at risk. Remember, these are already FDA approved, so all of these delays and costs really aren't adding anything in terms of patient safety or vaccine efficacy. And so we actually get some estimates that talk about, well, what's the health risk to patients? Because if there's less access, there's less vaccination, we're going to have increased incidence of disease. That increased incidence of disease is going to come with all sorts of health repercussions, and in some instances, even higher mortality, which is actually the highest cost of all. And then there's also the idea that if patients go through the effort to get to the doctor's office, the higher cost, less convenient place to vaccinate for many patients, that's going to have a cost both on the patient themselves in terms of higher costs and more time, but also on the entire healthcare system. One of the things we worry about is how do we control healthcare costs? Well, you certainly don't control costs by incentivizing people to go to the higher cost delivery for vaccines, and that's the other kind of framing of the costs. So that kind of framing, I think, is really important so that we can begin to understand the cost benefit of these regulations and really understand the more we put on, the worse that cost benefit ratio looks.
Thanks, Wayne. And it's really fascinating to think about all the implications for our healthcare system. So thanks for breaking that down for us. Turning to you, Esteban, the cost comparison between pharmacies and physician offices is a critical aspect of the report. Could you elaborate on how this cost of vaccinating patients at pharmacies compares to vaccinating them at physician offices?
Yeah, of course, Ben. As you said, it's a foundational principle and assumption of the research we did. Over the last decade or so, there's been ample evidence across systematic literature reviews, surveys, and more that suggests the cost of vaccinating patients at pharmacies is between 20 to 40% cheaper than the cost of vaccinating patients at physicians' offices. That depends on the vaccine where you fall within that range. So even on a per-person basis, it's a pretty significant difference. If you add that up over tens of thousands of people or even hundreds of thousands of people, the difference becomes shocking. And to speak to something Robert brought up before, there's better geographical access to pharmacies in lower income communities. So there's an equitable benefit as well on the patient side to increasing vaccine accessibility at pharmacies.
That's very interesting because I think the cost differences are really more significant than many might assume. This could lead to some important decisions for patients and policymakers alike. Wayne, you used the RSV vaccine as an example. We know why, since more than 80% of RSV vaccines in 2023 were administered at a pharmacy. What are the specific cost savings?
Well, and that is such an essential question. And the way we looked at it, because a lot of that depends on what will patients do, and that's very hard to know. So we try to kind of create a boundary in terms of where the costs are going to eventually manifest themselves. So on one side, right, one extreme, you could say, especially with a vaccine like RSV, which is seasonal, if you have a delay that's long enough and you don't get the vaccine out in time for that one season, you've lost an entire kind of, like a flu season, a cold season. Well, you also have an RSV season. So with the inability of pharmacists to be able to vaccinate, on one end, if everyone, that 60% number you mentioned at the beginning of our podcast, if all of them decided to wait to not get the vaccine, then that's the highest possible cost you can have on terms of health impacts, right? More people will be getting sick. There's a cost to that, and higher mortality rate, and there's a cost to that. At the other extreme, that entire 60% goes to the doctor's office. Well, if everyone that would have gone to a pharmacy goes to the doctor's office, well, then we're spending more to vaccinate. And so if everyone did it, that's the maximum cost in terms of higher healthcare spending. So those kind of create a bound in terms of how these costs can be manifested. And obviously, there'll most likely be some combination, so it would be in between those. But if all of the people who would get their vaccines at the pharmacy decide not to or wait, then we're talking about a tremendous cost. You're talking about lost hospitalization costs, because you have increased hospitalization of about $500 million to $1.5 billion, $1.4 billion. You have higher mortality costs that we economists would like to put an economic value of lives lost. And you're talking about that value of $15.5 to $26 billion. So you're talking about a huge cost in terms of increased hospitalization and increased mortality. The people who go to the pharmacy don't get the vaccine because we'd have higher amounts of RSV infection, higher numbers of serious RSV cases, which lead to hospitalization, and higher rates of mortality. So if the people who didn't go to the pharmacy don't get the vaccine, that's a tremendous cost. If they do decide to get the vaccine, they go to the doctor's office, then you're talking about an additional cost of about $1.3 to $2 billion. So either way, you're talking about a huge cost. It's either borne by higher healthcare expenditures or higher health costs on individuals.
Wow, I'm stuck on that cost that you just mentioned of increased hospitalizations and increased mortality. That's an enormous cost. So thanks for sharing this example. I really think the RSV vaccine example helps shedding a light on broader vaccination strategies. It's a great example. And Esteban, the report features a very complex and yet informative illustration. I know firsthand as it was actually hard to simplify that illustration while we were working with the designer to finalize the report. So when looking at that graphic, what stands out to you the most and what should our listeners take away from it?
Yeah, like you said, Ben, it's an overwhelming graphic. And to be frank, those complexities of the graphic are a perfect visual representation of the complicated system. So those complications, they're intentional. It's almost exactly how the system has been created over time to work. But across the chart, you'll see 9 different pathways. Depending on the pathway, there can be 1 step, there can be 2 steps, or even as many as 5. Each additional step adds more time and as a result adds costs. So the main takeaway is this: the more time you add, the higher the costs will be. If I were a policymaker looking at this and saw my state in one of the more convoluted pathways, I'd think, wow, what can we do to improve this and make it easier, not only on patients, but ourselves too?
Thanks for simplifying all this, Esteban. Robert, the report offers a comparative look at states with different regulatory environments. Could you give us one example of a state that gets it right and one that gets it wrong?
So, Ben, that's a great question because not all states are equal with regards to the complexity that they've created, right? So, for example, a state like Idaho has streamlined the process significantly, and it allows pharmacists to immunize upon FDA approval of a vaccine. Now, whether they do it or not, that's a different question we can get into. But one of the largest states in our country, New York, is one of the worst ones. It probably has erected more regulatory barriers for pharmacist immunization than any other state in the country. And you know what the sad part has been about this? Is that when we looked at the low-income community study that I referred to, in that study, we found that New York, actually in their low-income communities, has far better access to pharmacies. Far, I'm talking about one of the best accesses in the country compared to other states, than to physician offices that immunize. So in other words, all of these barriers that state of New York has erected and created is hurting minority patients or underserved communities. And this is where states talk from both sides of their mouth. In one way, they want to improve access for underserved communities, but in other ways, they create barriers that sort of like don't allow those patients to have equal access to more affluent communities that patients, frankly, can have flexibility in the day to go see a physician to administer those vaccines. And those are all of the stuff that we need to think about when we're doing all of these regulatory barriers.
And Robert, talking about barriers, considering the barriers and potential solutions you've identified, would you say that the key to enhancing pharmacist-led immunization lies more with federal adjustments or state-level reforms? And what steps can be taken to address these hurdles?
Ben, the steps are simple. Pharmacists should have the same authority to immunize a patient, similar to their physician colleagues. At this time, when an FDA approves a vaccine or CDC recommends a vaccine, physicians can just go ahead and start immunizing patients based on whether it's based on the FDA label or based on the CDC recommendation. And pharmacists should have the same capability of doing so. Administering a vaccine is not about diagnosis that everybody gets concerned about. It's basically if you're a patient, you qualify for it, you don't have any side effects, for example, with regards to some of the labeled indication side effects and everything else, then you're eligible to get the vaccine. And physicians are able to do so, and pharmacists should be able to do so as well. Now, having said that, it's not a federal fix. We've talked about this in the past in our podcasts, but the practice of pharmacy, the practice of medicine, the practice of nursing, any kind of practice in healthcare professions, dentistry, is governed by state law. It's not a federal law that governs it. Now, many of us who are licensed in multiple states and live in different states at some time in our career wish that it was a federal law that governed it because, there's no reason why a pharmacist practicing in Texas should not be able to do the same pharmacy practice in the state of Illinois. But unfortunately, again, this is old models of regulatory processes that we've erected. And because of that, it has to be state by state regulatory reform to allow pharmacists to have the same sort of authority to immunize as their physician colleagues.
Thanks, Robert. And to our listeners, as usual, we'll be dropping a link to the full report in the show notes. All right, my main takeaway here is that I learned that vaccinating at pharmacies is not only more cost-effective than at physicians' offices, but it also significantly enhances vaccine uptake, especially in low-income and underdeserved communities. But Robert, you're the expert, so I want to make sure you have the last word.
So Ben, as we've discussed on this podcast, and Esteban and Wayne did a great job of summarizing the study, look, 1, it's cheaper to get a vaccine at a pharmacy by a pharmacist. 2, it improves uptake when you involve pharmacists in vaccination. There's no doubt about it. There's literature that supports that. 3, there's better access to pharmacies than physician offices, especially in low-income communities and underserved communities that are overpopulated by minorities. Look, these patients in these communities that are underserved, most of them don't have the flexibility that affluent neighborhoods or people who are affluent and work in jobs that pay really well can take off in the middle of the day and go and get a vaccine at a physician's office. They work hourly wage jobs, and if they don't show up to the job, they don't get paid. So having access at pharmacies is super important. The last 2 points are even more important. 1, 90% of adult vaccinations post-pandemic are being conducted at a pharmacy by a pharmacist or a pharmacy technician. Patients prefer going to a pharmacy for their immunizations. And there's literature actually that shows minority patients favor going to a pharmacy than a physician's office for their immunization because of the flexibility and also because of the closeness to their residence of a pharmacy than the physician offices. To summarize all of this and give you a data point that everybody can relate to, in the United States, we assume that there is a Starbucks in every corner, right? In reality, there are 4 times more pharmacies, retail pharmacies in the United States than there are Starbuckses. So just take that in and think about it, that we all assume that Starbucks is right next door to us where we live, but in reality, there are 4 times more retail pharmacies to where we live. That's why pharmacies and pharmacists are far more accessible than any other healthcare professional for patients in the United States.
Well, thanks for breaking that down for us, Robert. That's very clear. And thank you all, Robert, Wayne, and Esteban, for such an informative conversation.
Wayne and Esteban, thank you so much for coming on. It's been a pleasure working with you on our second paper, actually. This is not our first paper that we published together, and more to come.
Thank you so much for having us. Great to be here.
Thank you very much.
And to our listeners, don't forget to subscribe to our podcast on Apple, Spotify, or wherever you might be listening, so you never miss an episode. And if you have a second, help spread the word by rating our podcast, writing a positive review, and sharing with your family and friends. It will help more people like you find us.
And as always, if you have any questions, thoughts, suggestions, we would love to hear from you. And you can send us an email at podcast@ghlf.org. And if it's a good idea and something we can address, we will definitely address it in our podcast. And who knows, we may invite you to be part of the podcast.
We definitely will. And before you go, make sure you take a listen to some of our other great podcasts on the GHLF Podcast Network. You can find all of GHLF's podcasts at ghlf.org/listen. He's Dr. Robert Popovian.
And he's Ben Blanc. We'll see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.